The last group of drugs in this big chapter of antihypertensive are the newest addition to our arsenal against blood pressure. These are the drugs that work on the renin-angiotensin-aldosterone system. Now, we all remember that angiotensinogen is the alpha-2 macroglobulin that is produced by liver cell as a precursor of angiotensin 1. It is the enzyme renin produced by juxtaglomerular cells of the kidney that really catalyzes this reaction. Angiotensin 1 has some activity, but not too much. It is primarily after its conversion by angiotensin-converting enzyme that it becomes the active metabolite angiotensin 2. Angiotensin 2 is a little peptide that binds to AT receptors, and it is the AT1 receptor that we're after. They are found in blood vessel, causing significant vasoconstriction. They're also found on zona glomerulosa of your adrenal cortex, causing desmolase and aldosterone synthase enzyme activity to increase so that there would be more aldosterone. In turn, aldosterone in your late distal early collecting duct is going to result in sodium retention with water to the expense of potassium. So having said this, there are at least 3 different spots on this diagram to place drugs. Remember always that your board loves site of action diagram, and here's one that is very famous. All the way at the top is a newer drug. This is the drug aliskiren. Aliskiren is our first renin inhibitor. By blocking renin, it should block the formation of angiotensin 2 and therefore indirectly prevent vasoconstriction and aldosterone secretion. Of course, there's also the famous ACE inhibitors, and ACE inhibitors are the drugs that all end up in pril, such as captopril. And ACE inhibitors will work on angiotensin 2 formation. Notice that they also work on the inactivation of bradykinin. Aliskiren does not work on this inactivation. Bradykinin is a big inflammatory mediator, and inflammatory mediators are not only vasodilators, so that they can help in the antihypertensive effect, but they also mediate the actual process of inflammation. So possibly some side effect of inflammatory nature will occur with ACE inhibitor and not with the other drug. The other possibility is to block AT1 receptors directly by what we call classically ARBs, angiotensin receptor blockers, and in particularly the drug losartan. In effect, anything ending up in sartan is an angiotensin receptor blocker. So as I'm looking at this diagram, I see direct-acting drugs such as ARBs blocking the AT1 receptors to angiotensin 2, and 2 indirect-acting drugs, the renin inhibitor aliskiren and the ACE inhibitor captopril. I can't help myself but reminding you also that beta blockers have an effect on this story. Never forget that beta blockers can suppress renin release. Now, they do not block the enzyme like aliskiren, but they can work on the control of renin secretion. What do we expect then from ACE inhibitors? Well, captopril and other pril, by blocking the formation of angiotensin 2, should prevent AT1 stimulation with a drop in aldosterone and a vasodilation effect from the lack of angiotensin 2. It is relevant to remember that bradykinin will build up by preventing its catabolism. An angiotensin receptor blocker, ARBs, like losartan and any other sartan, will block AT1 receptors directly, resulting in the same effect of ACE inhibitor, but with no interference with bradykinin degradation. Renin inhibitors with aliskiren as a prototype should block the formation of angiotensin 1, and in blocking the formation of angiotensin 1, hopefully offer the same results as ACE inhibitors and ARBs overall. Aliskiren, again, does not interfere with bradykinin degradation. Well, when we look at these drugs, surely they're used for hypertension and its management, but they have 2 major stories. They are protective of the diabetic nephropathy, and they are some of the best drugs we have to prevent remodeling and congestive heart failure. We cannot say too much about aliskiren yet, because understand that until we have some clinical trials that show after long-term use that their aliskiren is as beneficial, we can only hope it would be the same. But we can never jump to conclusion too quickly. It's always important to first study before we give the actual ideas that yes, this would be also a drug to use in diabetics or to use in people with CHF. There is established data for the previous 2 families. The main side effect of an ACE inhibitor is dry cough. it is considered the limiting side effect. It is actually more common in women than men, no idea why, but when it happens, I guess because we don't have a bradykinin antagonist, we really cannot treat it. The only approach is literally to stop the use of a captopril-like drug. This is when then your boards might ask you, what would you use next? And if you cannot use captopril, then use an angiotensin receptor blocker such as losartan. So a very famous point to remember here. All these drugs, aliskiren, ACE inhibitors, ARBs, will result in hyperkalemia. Hyperkalemia comes from the lack of aldosterone. Then these drugs have a big problem. You see, we always remember they're good for the kidney function of a diabetic. Fantastic. Does it mean they're good for every renal pathology? Absolutely not. Here is a very famous one to contraindicate the use of these drugs in renal artery stenosis. In renal artery stenosis, the blood supply to the kidney is actually decreased because of a narrowed renal artery. Well, in order to have adequate perfusion pressure in the glomerulus to allow filtration, there's only one way, the production by the kidney of renin, angiotensin II then constricting the efferent arterioles so that there is an increased resistance to the outflow from the capillaries of the glomerulus. Now, if I increase efferent resistance, remember out of your physio, this will increase capillary pressure in the glomerulus. This alone will allow the filtration of the blood and the formation of urine. If you were then giving a drug to someone with renal artery stenosis that would block the effect of renin, then you would actually prevent that increased capillary pressure in the glomerulus. As such, you would precipitate renal failure in people with renal artery stenosis. This is quite important because people with renal artery stenosis obviously suffer hypertension. They suffer what we call renovascular hypertension. Now, it is thought in current medicine that if you have a unilateral renal artery stenosis, well, you may want to still be able to use your ACE inhibitors or ARBs. But if you have bilateral renal artery stenosis, then it would be totally contraindicated. Here's the view from pathology if you want. If you're going to prevent one kidney from working, certainly you can live with a single kidney. However, remember that this single kidney will have to hypertrophy, do the job of two kidneys, and then will quickly suffer the results of hypertension, and that is glomerulosclerosis and renal failure. So really, common sense would be don't use these drugs in renal artery stenosis and absolutely contraindicate them in bilateral renal artery stenosis. As you can see, the last side effect noted on your book is that of angioedema. Angioedema is a catastrophic event, kind of anaphylaxis if you want, whereby potentially the swelling of the throat in particular could compromise the patient's breathing. It has been noted quite often with the drug captopril, and certainly as an emergency situation would require immediate cessation of the treatment. Otherwise, although ACE inhibitors are normally contraindicated in pregnancy, that is for the chronic treatment and management of hypertension in a pregnant lady, surely they are not considered class X. If you remember in our general principles, an ACE inhibitor is actually a class D drug, a drug for which benefits may outweigh the risk under certain situations. Those would be those of preeclampsia or eclampsia, for instance. So for an acute emergent use, an ACE inhibitor would be okay, especially towards the end of the pregnancy. Nonetheless, for a step one question, it is always relevant to contrast the use of drugs such as methyldopa, hydralazine, which are approved for pregnancy and hypertension management, and drugs such as ACE inhibitors, which would compromise the blood supply to the baby and have tremendous teratogenicity.